Okay, so just a couple. So OpenSim, if you're not familiar, is a freely available software application for visualizing musculoskeletal structures and simulating movements of humans and animals and more. The application includes tools for general purpose inverse dynamics, optimization to estimate muscle and joint forces. There are also methods to create simulations for motion capture, and then tools that allow you to analyze and visualize the results of simulations. So the first goal of our webinar series is to showcase cutting-edge research that's being performed with OpenSim. OpenSim is also a growing and geographically diverse community of users. That includes all of you who are joining us today. So the second goal of our webinar series is to provide a platform for the OpenSim community to communicate and collaborate. Next slide. So a couple of reminders about the webinar format. We definitely want your questions, but we'll address those at the end of the presentation, and we'll use WebEx's text-based Q&A panel. So start writing down your questions, and we'll take those at the end through the Q&A panel. If you need any additional technical help during the webinar, you can consult the guide on our website. Next slide. Oh, well, so with that, I'd like to introduce our speaker. So Julia Carr is currently a cardiovascular research scholar with the Department of Surgery at Washington University School of Medicine. She'll be starting a faculty position there next month. She was awarded an NIH postdoctoral fellowship in 2012 and has held a number of positions in industry over the years, working on biocomputational algorithms. Dr. Carr received her PhD in biomedical engineering from the University of Louisville for her research on analyzing ACL injury in female athletes, which you'll hear more about today. So we're excited to have you join our webinar series, Julia. And with that, I'll let you take it away.
Thank you, Jen. It's a privilege to speak on behalf of SymBios, the NIH Center for Biomedical Computation at Stanford University. My talk is going to be on modeling and simulating ACL injuries in young female athletes when they perform stop-jump activities, and in general, this refers to impact activities as well, any other impact activities as well. So here I'm going to show you a simulation of a young female athlete performing a stop jump with good form. And I'm going to show you a second slide in a little while and let you make the judgment call on which athlete you think is making is keeping good posture. So this is the recovery phase from a stop jump right after the athlete has jumped on the force plate platforms. We had employed two force plate platforms, two force plates for the athlete to jump on, and this is, as you saw, one of the athletes performing the stop jump or the part of the recovery while she performed the stop jumps. So in this slide, we have yet another athlete performing a similar stop jump and recovering from it. So as you can see, a lot depends on the posture undertaken by the athlete while they are performing the stop jumps once they hit the force plates. So I'm going to move on to the goals of my study or my dissertation project. I did my dissertation between 2007 and 2011. I used the OpenSim version 2.2, the platform on which I did all my simulation and analysis activities. My specific goals were, the first of my specific goals were to model and investigate ACL dynamics and also knee dynamics in young female athletes performing stop jumps. A second goal was, of course, the combination of those ACL strains and internal forces using the numerical simulations and the open sim environment. And a final goal was to show that dynamic loading, for example, when impact increases the jump height, it can lead to increased ACL loads and strains. So that my final goal is to show through simulation the increased effect of dynamic loading on the ACL. Why was I motivated to undertake this project? The background is that nearly 200,000 females participate in collegiate sports. These are young female athletes, mostly aged under 25 years of age. About 70 to 80% of those who injured their ACL, they do it due to indirect loading that are classified as non-contact. Non-contact injuries commonly occur when athletes are trying to recover from their drop and they hyperextend their knees, and right after landing or side cutting, they lock their knees in that hyperextended position. Finally, female athletes are 4 to 6 folds more likely, 4 to 6 times more likely to experience ACL injuries than males. And although it happens to both of them. I'm moving on to the background on the ligaments of the knee joint and the knee joint in particular. The important ligaments of the knee joints, there are 4 of them, are the anterior cruciate ligament, the posterior cruciate ligament, the medial collateral ligament, and the lateral collateral ligament. So the function of the PCL along with the ACL is to prevent the knee from twisting during loading of the knee, and also to prevent the tibia and femur from moving away from each other during impact activities or even low impact activities such as walking. The role of the other 2 ligaments are very similar. In this case, the LCL and the MCL prevent the knee from moving sidewise in the lateral medial directions. Before going further, I must say that this model does not include the knee patella, including which into the knee model, if someone wants to do that, would be a great improvement on this model. So a little bit of background on ACL tissue deformation. ACL tissues are, of course, passive tissues, and the ligament has a hierarchical structure starting from the collagen part to the fibrils. Then we have the fascinating crimping behavior of the fascicles, which make up the ligament, which are the basic structures of the ligament. So the ACL deforms in a forced deformation method. In a forced deformation way that is shown in the second diagram. We generally have an exponential toe region through which the ACL slightly deforms, followed by a linear region, and then that is followed by yield and failure. The ACL, like most ligaments, do not deform more than 15% of its resting length, and the forced deformation diagram that you see is one taken from an in vitro rabbit ligament experiment, which is very similar to the ACL forced deformation in human beings. So what happens during ACL loading? So during an impact, there can be adverse physiological effects that cause further destabilization of the ACL, and some of them include low knee flexion, large angles of knee valgus, which is valgus varus or abduction-adduction of the knee, and also low flexor extension ratios. These are the muscle activation recruitment ratios in the hamstring to quadricep and gastrocnemius to quadricep. If these flexor extensor ratios are lower, then it has been seen that ACL destabilization increases. I'm going to move on to our experimental setup. We had a total of 11 subjects participating in this study who were recruited from the Intramural Division of University of Louisville. They were all adults aged between 19 and 25. They were asked to conduct the stub jumps from platforms ranging in height from 30 to 50 centimeters in increments of 10. The subjects were fitted with reflective markers for collecting joint kinematics data, and the marker arrangement is shown on the diagram to the right. And they were also fitted with surface EMG sensors. These were wireless sensors that were fitted to the lower extremity muscles. We were limited in the number of channels we had on the wireless device, so we fitted the EMG sensors on 8 of the important knee muscles, which included the quadricep femoris, the vastus lateralis from the quadriceps, the bicep femoris, hamstring, and the gastrocnemius. So here is a bigger diagram of the marker arrangement. The marker arrangement is typically known as a modified Helen-Hayes system of marker arrangements. At that point, we did not model the arms, although it's very clear that the arms do contribute towards impact activities. However, at that time, the OpenSim model that I was using did not have arms, and we really didn't go into that aspect of the modeling. So the surface electromyography sensors that I used, those were wireless Adelphys double differential electrodes. They were placed on the muscle belly or with the metal parts oriented perpendicular to fiber directions. They were placed on, as I mentioned before, the quadricep femoris, the vastus lateralis, the bicep femoris, and the gastrocnemius on both legs. If you want to learn more about these surface electromyography devices, which communicated wirelessly with the Adelphys MyMonitor system, you can go to their website and look at their practicum. So the company is Adelphys. I'm going to move on a little bit now to the actual musculoskeletal modeling in the OpenSim environment and speak about the degrees of freedom. So the model I started with within the OpenSim environment actually had 23 degrees of freedom and 54 muscles. There was no ligament in that model, and it was being mainly used for gait. What I first did was to introduce a couple of extra degrees of freedom at the knee, which included the varus valgus, or adduction, abduction, and the internal, external rotations of the knee. So my biggest challenge while doing this project was that there was no passive ligament tissue structure in that model available in that earlier version of OpenSim, which was 2.2. So I basically took a Thielen muscle and modified it so that it would behave as a passive ligament and inserted it into the knee joint. So for the next few slides, I'm going to be talking on how I modeled that passive ligament in the knee joint. So if you look at the classic Hill-Huxley model of muscle tendon contraction, then you will always find a contractile element, which is the active element, a passive element, a parallel passive element, and a series element at the tendon junction. So this is a structure that is found in a muscle that actually activates. However, the ligament is a passive tissue, so I had to take a Thielen model and just negate the contractile element and just do away with the contractile element so that I would have a passive tissue as my ACL. So I basically used that passive tissue and inserted it into the knee joint. I modeled every individual more or less every subject more or less on an individual basis, because if you do not place the ACL in the right orientation, then you run into the problems of it popping out during simulation, which you don't want to. So individual care in modeling the ACL is an important step to getting successful results. So where did I place the ACL? So I placed the ACL into the insertion points in the intercondylitic eminence of the femur and the front meniscus of the tibia. And here is a sagittal and frontal view from the OpenSim environment on how I modeled this into the existing OpenSim gait model. So the next question is, how do I set up the ACL as a passive tissue? And as I mentioned at that point in time when I was doing my dissertation, we really did not have a ligament structure there that I could use as the ACL. So before we go into the material properties of the ACL, I want to speak a little bit about constraining the knee angles. So we have the 3 degrees of freedom at the knee: the flexion extension, the varus valgus, and the internal external rotation. You want to make sure that you have proper ranges for these angles. For example, it's surprising how much flexion a subject can go through during impact activities, so for which I had to make the maximum flexion angle at 120 degrees, and the extension was at 10 degrees. The varus valgus and internal external rotation ranges I took from available literature, and they're generally between 10 degrees of varus and 10 degrees of valgus, and the same for internal external rotation. So what I did to the model is I modeled the isometric force and length point at the highest degree of flexion, which was at the 120 degrees. At that point, the optimal fiber length, and here I'm showing an average, was slightly over 3 centimeters, and tendon sac lengths on the 2 ends were about 1 centimeter each. Once again, making sure that those that ligament and osteoligamentation instead of the tendon, if you look at it that way, part does not pop out of the knee during simulation. One other thing that I did to make sure that optimal fiber length was the shortest at the 120 degrees of flexion was to minimize the strain at that isometric point, so it became the shortest and the resting length. The other things that you want to do to make sure that ACL forces do not go beyond the 1,000 to 2,000 Newton range that we see in normal human ACL biomechanics by adjusting the shape factors, the K-active shape factor, which you really want to reduce because there's no activation, so you want to almost put it down to 0, and the K-passive shape factor that you want to adjust so that your range of ACL forces remain between the 1,000 to 2,000 range. So here's a diagram showing just the passive elastic element, where I have taken off the contractile element, the active contractile element, and this was achieved by all the points that I made in the previous slide on how I set up the passive tissue. So how does the tissue behave in a 3 degree of freedom knee when we set it up as a passive ligament? So we have the degrees of flexion between 120 degrees of flexion and 10 degrees of extension. And as a ligament, it should have the least amount of internal forces at flexion, at maximum flexion, and the most at an extended position when the knee is extended and the subject is in an erect posture. So here is the force versus flexion degrees curve that I achieved with my ligament modeling. However, one should remember that other than flexion extension, we also have a couple of other degrees of freedom in the knee. And the force behavior of the ACL is going to change according to those degrees of freedom. So eventually, after I modeled the ligament, other than the flexion extension and force behavior, I also had a couple of other ACL force behavior with the other 2 degrees of freedom, which was the varus and valgus and IE rotation. So on the left-hand side picture, it shows the valgus to the right and the varus to the left. Imagine that you're at the extended knee position when the subject is in an erect posture, and you have a force at that point in the ACL. So that extension force is what we have during a 0 degrees of knee position or at full extension. However, that force is going to change if you change the degrees of freedom. If you change the varus valgus degrees of freedom, that force is going to change and get higher with valgus and get lower with varus. And if you have internal external rotation, it is also going to change. But I found with almost all of the models that internal external rotational changes, force rotational changes, were not that high. The variation was less sensitive. So, So these slides describe how the ACL was modeled as a passive tissue in the knee, and following which we are going to move on to the actual simulation steps of the musculoskeletal model. So musculoskeletal simulation. So there are some underlying assumptions, and I'll go through these quickly, to musculoskeletal simulation, and most biomechanical engineers are aware of that. So the basic assumptions are that all segments are rigid bodies with constant mass. The bones and muscles don't change in mass. The muscles are attached to hinge joints at the 2 ends of the segment, and that the center of the mass, or the column, remains fixed for the entire duration of the simulation. So here we see the lower extremity with the hip joint, and in my model, which is also the same in the gait model, the foot was further divided into the talus, the calcaneus, and the toes. So there was about 6 segments in the lower extremity, including the hip joint. Moving further on, musculoskeletal simulation. The simulation steps I followed is more or less the ones that are found in the OpenSim or followed in the OpenSim environment. That included static scaling using marker positions from either static or dynamic trials, inverse kinematics for finding joint coordinates from marker positions, residual reduction, where you eliminate residual forces by optimization, computed muscle control, where muscle force, a very important muscle force contribution, which was one of the important findings of our studies towards joint torque, is found. And one usually uses dynamic optimization to do that. And forward dynamics, which recreates joint kinematics using the muscle forces that were found during computed muscle control. So forward dynamics, and we will talk about this in a couple of slides, was actually done so that I could validate my results from this study, the results from inverse kinematics and computed muscle control, so that I could validate the joint coordinate data and the muscle activation data that I obtained from the previous simulation steps. So here is the sequence from a typical trajectory. The person or the subject lands the touchdown. Then the subject will crouch down, hopefully with good posture, wherein the maximum forces occur. The ground reaction forces are shown by the arrows, from which the person starts recovering and then goes on to stand in an upright stance. So those were all parts of my modeling background, and now I start with the results from my study. So the ground reaction forces, were very much expected, with the highest ground reaction force from the 50 centimeter jump, followed by the 40 and 30. Since the athletes who participated for this study were mostly healthy and trained athletes, there was not abrupt changes in the ground reaction forces through the jumping heights. And it would be interesting to find out what happens when unconditioned athletes actually perform jumps through those heights. So moving on to the results of knee flexion and valgus angles, I computed the knee flexion and valgus angles through both inverse kinematics and forward dynamic simulation, and here are the angles that I obtained for flexion and valgus. I observed that the maximum valgus actually occurred during maximum flexion, and that was during the crouch position right after touchdown. The highest occurred for the 50 centimeter jump, and I found that the two were very much the amount of valgus that occurred during flexion was very much coordinated. And the knee flexion and valgus moments occurred in the same way. So the right knee flexion moments and the right knee valgus moments are shown here, and here we can assume symmetry with the moments in the left knee happening in a similar way. We've also found that the 50 centimeter jumps had the highest moments for both flexion and valgus, and that the occurrence of the two peaks were very much coordinated. So from there, I'm going to move on to our validation. As I mentioned, that validation was performed with forward dynamic simulation, where we use the muscle forces from computed muscle control to actually activate forward kinematics. So we compared the angles from forward dynamics, which is the knee angles, of course, between forward dynamics and inverse kinematics, and we saw very good correlation between these angles. We were actually able to go through full forward dynamic simulation of the recovery phase, that is between touchdown to standing up to erect posture, and some of the correlations for the right knee angles, flexion and valgus mainly are shown in this slide. Internal, external rotation, we did not have a great deal of variation, and those correlations were almost as perfect. So in the final part of my dissertation, I worked on a 6 degree of freedom model. The model that I have been showing you so far was actually the 3 degree of freedom model with only the 3 rotational degrees of freedom. I finally worked on a 6 degree of freedom model with 3 rotational degrees and 3 translational degrees. And the main reason for doing that was because I wanted to observe the anterior-posterior forces in the knee, the anterior-posterior shear forces in the knee and ACL, because recent studies have shown that these forces combined with valgus can cause higher ACL loading and therefore higher possibility of damage. So what I did with the 6 degree of freedom, other than using all 6 degrees of freedom, was also compare the activations, the simulated activations from the muscles with actual EMG readings that I took with the Delta SMI monitor system. And here are 4 right muscle EMG readings and simulated activations. So for the bicep femoris, the gastrocnemius, the rectus femoris, and the vastus lateralis. So what we found was the rectus femoris had the best correlation in all of them, which is not surprising because it is one of the largest muscle, and a lot of the times placement of the sensor on the muscle belly can affect the kind of readings that or recordings that you get from the sensors. So at this point, I'm inconclusive as in whether I could have done a better job with sensor placement. However, it is always possible to get both EMG readings and simulated activations and compare the two. So here is the right and left anterior posterior shear that the results that I got from the forward dynamic simulation. As I mentioned, that the anterior shear forces combined with knee valgus can have the propensity to cause more damage to the ACL. And what I found that the shear forces were quite high in comparison to body weight. So the peak forces, as you can see, went up to as high as the body weight of the performing subjects. And this was an important finding of this study, and this is a direction that is also being pursued by other studies who believe that the AP shear forces have a significant effect on ACL loading. So one of the final results that I'm going to show you is the ACL fiber forces and strains obtained from computed muscle control and forward dynamics. We found that the ACL forces, which should be lower during the first phase of recovery or right after touchdown, were actually not as low as we expect, and that is possibly due to the knee valgus. They were much higher in the 50 centimeter jump than either the 30 or 40. And the effect of the valgus, as you can see from both the force and strain diagrams, were quite significant. They were not as significant as I mentioned in the 40 and 30 centimeter jumps. And that is expected because the 50 centimeter jump was a substantial landing amount and with much higher ground reaction forces and also requiring much better posture control by the subjects. So now I'm going to rerun the forward dynamic simulations from the two subjects that I showed earlier. So this is the subject who has the better posture. And following which, here is someone who has considerable knee valgus, bad ACL posture, and also had bad knee angles and more forces in the ACL. As you can see, they don't flex much. The subject doesn't flex much, and there is considerable valgus. So I'm going to move on to the concluding part of this talk and state a few study limitations. So these ACL biomechanics simulations were done under only a simulation environment, and there is no real life data available, as in we did not insert a chip into the knee to record data or anything similar. It was all done non-invasively, and we took the motion capture data and simulated ACL biomechanics from it. However, we did do the validation study with forward dynamics, where we compared the results of the forward dynamics joint coordinates with those from inverse kinematics. A second limitation is that within the open syndrome environment, the muscles and other soft tissues are still modeled as line segments, and possible more lifelike appearance to those tissues probably would make it a more believable or a more put a more lifelike picture to it. Then there was the differences in the experimental and simulated isometric forces, or rather I'm talking about the activations, as we saw with the data from the simulated activations and the recorded EMG sensors. The muscle activations from knee muscles were restricted to the recording of muscle excitations and activations from knee muscles were restricted to the quadriceps, the hamstring, the gastrocnemius, and no other activations were simulated or EMG data recorded from these muscles. It would be great if somebody can actually incorporate more muscles during simulation and also during motion capture, and see how these muscles activate and how their force and what kind of forces they undergo during impact activities. So from here, I move on to my conclusion, and my conclusions were very basic, which were ACL strains and loads increase with stop jump height. The knee valgus angles increase with stop jump height. Knee valgus moments and angles also increase with stop jump height. So the takeaway message from here is that it is possible to model impact activities performed by athletes within the open sim environment. I think that there's a big possibility of modeling this stuff with OpenSim, and the model that I created and uploaded into the project, into my project folder in the OpenSim website. And I believe that this kind of simulations can help female athletes or help the biomechanics community in understanding how these injuries occur, and also in providing feedback to these athletes for improving their posture and maintaining safety. And that was my talk, and I'll transfer it to Jen.
All right. Thank you, Julia, for a great talk. Now it's time to get started with the Q&A session. So hopefully you guys have come up with some questions. As I mentioned at the beginning, all the questions will be text-based. Julia, maybe there's if you go forward one more slide, I think there's a little instruction.
Yeah, sure. I'm sorry. Yeah.
Yeah, there we go. So find the Q&A box in your WebEx controls. Type in your question. Make sure you select to ask all panelists so that I see your question come through. So go ahead and get your questions in. While we're waiting for the audience to type in their questions, I'll go ahead and ask one. So one of the limitations you noted was discrepancy between your simulated activation and your measured EMG. I wonder if you have some ideas for what the source of this discrepancy might be. For example, the optimization you were doing, I'm assuming you're minimizing the sum of squared activations. Do you think for your activity that's what real people are trying to do?
So I think that if we make those, the further we take the excitation activation towards what happens in real life, the better it will be. So right now we square the sum of those activations, and I believe that maybe if we went in and included some more optimization steps in that, maybe using a weighted sum of the squares of those activations or other steps, then that would possibly give us a better option and more choice on how to obtain those results.
Okay, so a follow-up question from Ching Sai, an audience member, is, okay, so there was this difference in between muscle activation and recorded EMG. Are you concerned that this may have affected your ACL loading results? How do you think it might have affected your ACL predictions?
So to start with, the ACL is a passive tissue, and it has nothing to do with the activations of the muscles. And having also said that, the ACL is fixed or inserted between the femur and the tibia. So a lot of the ACL forces are coming from the way that the tissue is lengthening. So depending on how your knee is moving, your ACL is going to lengthen, and that is how your extension forces are going to build up. So the internal forces, although everything is cumulative, I don't think the actual internal ACL forces are very greatly affected by the actual muscle activations.
I mean, the loading in the knee joint does really depend on what muscle forces are. Did you maybe do any sensitivity testing to see how changing muscle forces affects that ACL strain?
Yes, one could do that. That's certainly a possibility to do a sensitivity testing. And I am not right now. Is that possible through OpenSim?
I mean, we have some scripting functionality where you could, set up a loop to apply different muscle forces and look at how that changes your ACL strains.
Yes, I'm sorry, that is another limitation. That is not something that I did during my project.
Okay. Let's see. So we have lots more questions coming in, which is great. Now we have some questions about kind of how you set the parameters of your knee model with ligaments. So from Cyril Donnelly, he asks, can you explain a little bit more about your approach to estimate the resting length of the ACL?
Yes, so as I mentioned, to the resting, I made the isometric length at the maximum angle of flexion at 120 degrees. And I made sure that there was no strain at that isometric point, so that became the smallest length of the ACL, and from which the tissue passively stretched from maximum flexion to full extension. I also reduced the shape factor for the active force length relationship, so that there was no active forces or hardly any active forces. You might also have to adjust the K passive shape factor, which is so that your muscle forces don't go beyond a maximum of about 1,500 newtons to 2,000 newtons.
Okay, thanks. Now we have a question from Julie Thompson. Do you think the inclusion of arms in your model would have significantly affected your results and conclusions? And if so, how?
Yes, the arms would definitely contribute towards posture, and it would definitely impact the simulation as well. At that point, I was constrained by the gait model, and so I simply just did not include the arms at that point, and that was definitely a limitation of that study. And how would the arms contribute to the forces? Well, the forces that you get through the ground reaction are transmitted throughout the body and is balanced by the whole body. So absolutely, the arms would definitely balance some of those forces.
Okay. So we have time for a couple more questions. If you guys in the audience have questions, go ahead and type those in. So we have a question from Giuliano Lamberto. So some more questions about how you defined your knee model. So what about the origin and insertion of the ligament? Did you use literature data to define those? And if yes, what paper did you adopt?
I did search literature for finding out the length of the insertions into the femur and tibia, and also definitely the length of the ligament. And right now I cannot remember the literature name from the top of my head, but the project files that I uploaded has both of my publications in there. If you look through those, the references should have one of those publications, or I can later on send it by email to Joy or you, and you can pass it on to him.
Okay, yeah, we'll definitely send out a follow-up email that has links to any relevant websites or papers. Okay, so I think we have time for one more question. One just came in from Jos Van Rentergem. Apologies if I did not pronounce that correctly. So his question, there are people from orthopedics backgrounds that believe that over the course of an exercise session, the thickness of meniscal discs may vary and therefore lead to increased ACL strain under certain circumstances. Would this be something you think you could model?
Yes, you could definitely model that if you modeled the meniscus as a tissue. So just as you model the tendon or the ligament, you would have to model that as a tissue with material properties that are basically passive material properties that are appropriate for the meniscus. And actually, meniscus damage is very, very important, because all those avulsions and tears that happen in the knee when one injures oneself during an impact activity, that definitely affects the meniscus, and that eventually goes and destabilizes the ACL. So to model the meniscus, you would have to follow a similar pattern where you have a passive tissue presenting the meniscus, and you define its its force length curve based on its passive characteristics.
Mm-hmm. All right, thank you. Thank you everyone for all the great questions. I think that's all the questions we have time for today. And thank you, Julia, for a great talk as well. Can you move on to the next slide for me? Okay, so we answered questions. One more slide. Okay, so I definitely want to acknowledge the funding sources that support the OpenSim project. So OpenSim and this webinar series are supported by several grants from the NIH, including an NIH grant that funds our National Center for Simulation and Rehab Research. We're also supported by the DARPA Warrior Web effort. I really want to thank everyone for a great discussion, and Julia again for a great talk. A few more questions have come in after the buzzer, and we'll get you in touch with Julia and pass those along so we make sure everyone's questions get answered. You can also, next slide, find out more information. You can find out more information about our center, upcoming events, and other resources for the OpenSim community on our website. That's opensim.stanford.edu. And we also ask that you please complete the survey that will appear in a pop-up window at the conclusion of the webinar. This will help us improve the webinars and choose upcoming topics. So thank you everyone for participating. We hope you'll continue to stay involved with OpenSim. Thanks.
Thank you.